Good evening, everyone, and welcome to our fifth live webinar on cardiovascular pathology. Today, we will be revisiting the cardiac pseudoneoplasms. Our speaker is Dr. Felipe Templo, and he is joining us from the Philippine Heart Center. The talk will be followed by a live discussion by our expert panelists. We will also be accepting questions for discussion through our Facebook page, Cardiovascular Pathology. I would like to invite you to begin your talk, Philip. Philip, I would like to invite you to begin your talk.
Yes, thank you. Good evening. I hope everyone is staying safe tonight. Also would like to say good evening to most of our viewers in India and also here in the Philippines. And good morning if we have some viewers in Europe or other parts of the world. I'm Felipe Templo Jr. I'm anatomic and clinical pathologist from the Philippine Heart Center. And I trained in that center also with a one-year fellowship in cardiovascular pathology. And I've been in the center also since 2009 as an attending pathologist. So that's nearly about more than 10 years. So my talk is basically part of my limited experience of this cardiac pseudoneoplasm and also some of the case report, case series, and review articles over the past 10 years. So in general, cardiac tumors, whether benign or malignant, are really rare, and majority of these are benign neoplasm. So we actually see few of malignant process, but the main concern basically of cardiac neoplasm is their mass forming effect. Of course, with the malignancy, they can also metastasize. So in this case, the cardiac pseudoneoplasms are even rare. They are classified as cardiovascular pseudoneoplasm because their neoplastic nature are not fully elucidated. Some of them are believed to be neoplastic, but there are debates whether they are also inflammatory or hamartomatous in growth. So basically, we do not have a lot of articles about cardiovascular neoplasm. This one was published in 2010, about 10 years ago, by Dylan Miller and Henry Tazular in the Archives of Pathology and Laboratory Medicine. Here they discuss only about 5 pseudoneoplastic lesions: the inflammatory myofibroblastic tumor, the hamartoma of mature cardiac myocyte, the MICE or your mesothelial monocytic cardiac excrescences, your calcified amorphous tumor, and lipomatous hypertrophy of the atrial septum. Another significance of this lecture is for proper identification, because we do not want to provide aggressive surgical intervention and even aggressive medical treatment for these lesions. Basically, the objective of this lecture is to describe some of the tumor-like or pseudoneoplasms of the heart, with focus on the gross morphology, histopathologic features, and more importantly, the differential diagnosis. And we will also mention some of those immunohistochemistry studies to differentiate this from malignant tumors. And since the last publication was 10 years ago, we can also cite some of the current perspective of this cardiac pseudoneoplasms based on the recent case report, case series, and review articles. So the lesions in focus will be the first 5, which was also discussed in that article: the inflammatory myofibroblastic tumors, the mesothelial monocytic cardiac excrescence, the lipomatous hypertrophy of the atrial septum, the hamartoma of mature cardiac myocytes, and calcified amorphous tumor in this sequence. But I will also include the three more lesions: the papillary fibroelastoma, the cystic tumor of the atrioventricular node, and histiocytoid cardiomyopathy. So this is basically from my limited experience as well as some articles during the past 10 years. As I mentioned earlier, the clinical implication basically is these pseudoneoplasm are associated with significant mortality and morbidity by valvular function, by cardiac conduction, and electrical activity. Of course, they can easily lead to obstruction of blood flow and embolization. And a few of this can actually mimic malignancy in terms of clinical presentation and even by histopathologic features. So I will first discuss the inflammatory myofibroblastic tumor, or IMT. This tumor actually is not uncommon because we can actually see this in many other organs like your liver, lungs, or uterus. However, the presence of inflammatory myofibroblastic tumor in the heart is still very controversial. In the previous article, it is said that there is still a debate whether this is a true neoplasm or not. So between that period, I could not find any articles that fully elucidated the neoplastic nature of this tumor. So some would say this is also an inflammatory or, or reactive process. So we will include here. So basically, if the tumor is excised completely, the gross appearance would be soft, translucent, but there are varying textural variation. They can also be fleshy or fibrous, as in this case here. So on low power magnification, we can see the prominence of inflammation on the different parts of the tumor. So they varies. And we can also see that the tumor has some loose areas or less cellular areas and some compact cellular areas. But the inflammation are prominent and consist mainly of your lymphocytes, plasma cells, granulocytes, and also the presence of eosinophils can suggest that this is an inflammatory myofibroblastic tumor. In this photo also, we can see that the cells, these are myofibroblastic cells, which can be spindle, rounded, or epithelioid. And I think in this slides here, there is some low level of atypia, but in general, the atypia here is not significant, and the mitosis is only about less than 2 per 10 high power field. So the cells, the myofibroblastic cells, are described as having elongated nuclei, vesicular chromatin, and prominent nucleoli. And of course, here we can see this myofibroblastic lesions or cells are positive against actin and vimentin here. This is actin and vimentin. Also, they are positive with desmin and smooth muscle actin. And we can see here the inflammation. So basically, this tumor has no predilection to specific chamber, but they can also be present as a polypoid mass or they can arise from endocardial surfaces. One thing that this makes tumor probably a reactive or inflammatory, as the name implies, because they present with syndrome like fever, malaise, weight loss, and thrombocytosis. And also, they can elicit the so-called cytokine storm or cytokine surge because of they can release we have the so-called inflammatory myofibroblastic tumor interleukin-6 release. And mainly the concern here is obstruction, but they can also embolize to different parts of the body. And so it is important that a surgical intervention be done properly to prevent any symptoms or complications. Your differential diagnosis here would be your myxofibrosarcoma, also a very rare cardiac tumor, your low-grade fibromyxosarcoma. But these two tumors does not have any inflammation or significant inflammation to contrast with your IMT. And the blood vessels here basically are more curvilinear compared to your IMT. The other one, of course, is myxoma. I think from my experience, we can see myxoma with many inflammation, but of course, it is important to check for your myxoma cells and quartz myxoma cells and the perivascular ring. So in this is a study in our center. They were able to describe at least 6 IMT tumors or inflammatory myelofibrotic tumors, and they tested this for proliferation markers like p53, BCL2, and Ki67. The p53 and BCL2 mainly shows less than 1% expression, but the Ki67 is about 6 up to 12%. But overall, even with this proliferation marker like the Ki67 higher, about 12%, the overall outcome is not unfavorable, or the behavior of this tumor is generally benign. So our next tumor, our next lesions is your mesothelial monocytic incidental cardiac excrescence. So this lesion was first identified by Luttringer in 1990, described as a tumor resembling histiocytoid hemangioma with increase in mesothelial differentiation. So grossly, this is described as gray-white to dark red to brown and associated with thrombus. It can be very microscopic, but it can grow to up to 3 centimeters in diameter. Usually in a day-to-day pathology work, this is submitted by your cardiovascular surgeon together with a valve specimen or any other open heart surgery. Maybe they are curious if this is a very big thrombi, a vegetation, or probably really a tumor. So there are theories about this, but the overall agreement for this development is that this is an aggregation of histiocytes, your mesothelial cells, and fibrin, similar to how you do the cell block. So it is really a product of a mechanical intervention in your thoracic area. But there are some pathogenesis. This is supposed to be initiated by suction catheter tips and other surgical endoluminal instrument, and sometimes occurs spontaneously when a mesothelium-lined space is entered or opened. So to differentiate this, so usually this is your mice. So we can see here in the slides 2 groups of cells already. There's a gland forming and sheets of cells. This is a better magnification. You can see glandular cells here and sheets of cells. So these cells here are positive for positive for cytokeratin like AE13, while the cells here in sheets are positive for CD68. Now, to further illustrate that, we basically have 2 types of cells here. The histiocytic cells, which are arranged in sheets mainly, and your taller columnar or cuboidal cells. So your histiocytoid cells or histiocytic cells is positive for CD68, and your taller cuboidal or columnar cells is positive for CK, also for calretinin as well. But there are variations in the appearance of your mice. Like in these slides, they're all appearing very solid. So these 2 cells are seem to be admixed with one another here. Now this one is a more developed. The taller columnar or cuboidal cells are arranged in tubules or glands. easy to differentiate from your histiocytoid cells in the background. In this pattern, the taller columnar or cuboidal cells tend to be arranged in sinusoids. And now this is more of a immunohistochemistry, so they are positive for AA13, cytokeratin, EMA, and other epithelial markers, while the background cells are positive for CD68. Now they performed electron microscope studies here. So the histiocytoid cells here is well, in microscopically, if closer magnification, they are round to oval with well-defined nuclei and prominent nuclear groups and occasional nucleoli. And so on electron microscopic exam, they are typically the structural morphology or the structural features are very similar to histiocytes, with convoluted nuclei, prominent nucleoli, and the cytoplasm is rich in reticulin and surface pseudopodia. Now, these taller columnar or cuboidal cells, they also studied this in electron microscope, and they would also show similar findings with your mesothelial cells, having some intermediate filaments and surface microvilli with well-developed desmosomes. So the theory basically is that this is of histiocytic in origin, both proven by immunohistochemistry and electron microscope, and this is really of mesothelial in origin that can be proven both by your immunohistochemistry and your electron microscope studies. You can also see occasional inflammatory cells within the mice. And basically, the main differential diagnosis here is your localized mesothelial hyperplasia. But your mice does not really have blood vessels, prominent blood vessels, or supporting stroma, which is the universal finding in localized mesothelial hyperplasia. So that effectively differentiate this from your localized mesothelial hyperplasia. You can see this in many cardiac chamber, in cardiac valves, in pericardial sac, ascending aorta, and even in bronchial biopsy, probably, and endomyocardial biopsy. So basically, this is described as free floating by the surgeon. So floating in your surgical field, and sometimes described as possible contaminants, but they will submit this, and these features would be present in the microscope. The other term for this is, or rather the old term is your nodular histiocytic / mesothelial hyperplasia, which is not a good term because this is not really a mesothelial hyperplasia, evidently by lacking your supporting stroma and blood vessels. Now, for these features here, when the tall columnar or cuboidal cells are well developed, or they forms prominent tubular or glandular cells, this can effectively mimic a metastatic carcinoma or metastatic adenocarcinoma. So from my experience, this is also the most important thing to rule out. However, some of the authors, I encountered 2 articles saying that even if this lesion is proven to be a mice from your immunohistochemistry studies, we cannot entirely rule out the presence of concomitant metastatic adenocarcinoma, like in this case report here. So still, it's important to work out this patient with other diagnostic, like maybe a tumor markers or other imaging, to really rule out the absence of, or really rule out your metastatic adenocarcinoma from elsewhere. Next lesion is your lipomatous hypertrophy of the atrial septum. Again, this can be mistaken for malignancy, especially by imaging. And this is more of developmental aberrancy and rather than an acquired neoplasm. The pathogenesis described here is that during your embryogenesis, Your right and left atria divides by progression of infolding of the roof of the upper and posterior wall of the rudimentary common chamber along the midline. Your mesodermal tissue are then drawn into the wall of the primitive atrial septum during the process, and pockets of intraop adipose tissue remains after the heart is fully formed, and thus you develop this lipomatous hypertrophy of the atrial septum, or the LHAS. Obviously, this is prominent in your right atrium, and this is age dependent, most commonly seen in patients above 50 years of age. And there is arguably a weak association with obesity. Grossly, this is very similar to your fatty tissue on the cut section, with probably more pronounced fine fibrous tissue. But take note, there is no true capsule here, and this will be later on noted in the microscopic examination. So here, we can see there's no through capsule, and they are composed mainly of mature fatty tissue, and both your brown fat and mature fatty tissue. Now, the main concern here is in differential diagnosis with some malignancy. Because they don't have the well-delineated capsule, they seem to be merging imperceptibly with your cardiac myocytes. And your hypertrophic cardiac myocyte would usually shows enlargement and squaring of the individual nuclei. And if the section is transverse and does not show your cytoplasm of your cardiac myocyte, this nuclei can mimic a malignancy and can be mistaken for lipoblast. Sometimes this lesion can also interrupt some of the ganglion cells, and as we know, some of the ganglion cells also exhibit moderate degree of nuclear pleomorphism and conspicuous nucleoli, and this can be mistaken for malignancy as well. So as I mentioned earlier, this is older, usually seen in patients older than 50, although you can see this in also in children. It is more common in women and generally asymptomatic until a certain level of growth. So the presentation can be a supraventricular tachycardia, or SVT, and also this is one of the very rare benign lesions in the mediastinum that can present with superior vena cava syndrome. So here they seem to be merging with your mature cardiac myocyte, and if this mature cardiac myocyte are hypertrophic, that can mimic for some lipoblastic or other malignancy. So like in here, this is an intraop cardiac myocytes showing some pleomorphic hyperchromatic nuclei, and if not taken properly or not sampled properly, this can be mistaken for malignancy. So as I mentioned earlier, the main differential diagnosis here is a cardiac lipoma, another very rare, but this is a true tumor. And of course, you have to identify a true capsule here to be mentioned for lipoma. And of course, your liposarcoma, this can mimic liposarcoma, again, because of those intraop nuclei of your mature or hypertrophic cardiac myocytes and even ganglion cells. Fortunately for the imaging, your 2D echo, this lipomatous hypertrophy of the atrial septum, it can show the typical bilobe dumbbell appearance. Also, even in your CT scan, they can present with your typical fat tissue signal characteristic. And in MRI, they would also show the characteristic fat suppression sequence. So this is again in our center, we had a case report, but this is not the lipomatous hypertrophy of your right atrial septum, but it was one of the differential diagnoses when we were trying to elucidate this lesion. But in our case here, we actually identified a true capsule, so we effectively ruled out lipomatous hypertrophy of the atrial septum. Next lesion is your calcified amorphous tumor. So for me, I have not actually encountered this personally as an actual case, but only as a study slide. Sorry. So perhaps one of our panel here can fully expand here with their experience about this specific pseudoneoplasm. So grossly, this is a conglomerated, described as a conglomerated red-brown, dry, clot-like material with tendency to crumble. It is also chalky in appearance, and focally mineralized calcification can be obvious on the outside of the tumor, and this may require decalcification prior to processing. Again, the presentation clinically and by imaging can raise, this lesion can raise for suspicion for malignancy, especially with a differential diagnosis. So histologically or microscopically, it would show central areas of calcification, and the outside is covered by fibrine material here. This is, for example, this is the anchoring cardiac myocyte. There are areas of your calcification, and outside are your fibrine. And sometimes the periphery of the tumor would also show significant inflammation. Since the center of this tumor is your calcification or your calcium, the outside fibrine, the significance of this is this can emboli to different parts of their body, and this is the danger of this tumor here. So again, we can describe here as a degenerating fibrine with central nodular calcium deposits, or sometimes they look like an osseous metaplasia and some mild inflammation on the outside. Sometimes also the fibrine can become very organized, and they can form fibroblasts, capillaries, and myxoid stroma. You can also see hemosiderin deposits and cholesterol cleft. Okay, sorry. So here this can occur in any parts of the cardiac valves, but the most common location is your mitral valves. It can grow up to 9 centimeters. And again, the symptoms is the embolic phenomenon. It can also cause shortness of breath or topnia. Although this is basically benign, this is one of the few pseudoneoplasm that can recur. And even during complete excision, sometimes some of this calcium or calcified deposits can remain within the area. And although this will not really present with any symptoms, even if the residual calcium is not again fully excised. So here again, these are the center of your tumor here with calcification and some fibrine perhaps on the outside. So these are the center of the tumor, and again the fibrine. The fibrine here become very organized already with some blood vessels and capillaries. Your differential diagnosis here varied from osteosarcoma, probably very rare in the heart. I have not seen osteosarcoma intracardiac. Your calcified myxoma, which we can rule out if we have to sample the lesion properly. We have to see the myxoma cells in some areas. Your mural thrombi is also a differential diagnosis, and they are pretty much similar to your non-infectious thrombotic endocarditis. Now, with this calcified amorphous tumor, the initiating factor leading to this fibrine aggregation as a reason for this tendency to form and to mummify and to undergo dystrophic calcification is still not clear. So this is probably more of again, a reactive process. Next one is your hamartoma of your mature cardiac myocyte, or HMCM. This was first described in Japan in 1988. And again, with the presence of this tumor in imaging, this is suspected to be a cardiac fibroma, a rhabdomyoma, or even an invasive malignancy. The most common location here is in the wall of your ventricle. And sometimes if a biopsy is taken, because this is composed of some hypertrophic cardiac myocyte with nuclear polymorphism, this can be interpreted as in the frozen section as a malignancy, and then this is sometimes a point of disbelief between the surgeon and the pathologist when the whole section is excised and diagnosed as hamartoma of mature cardiac myocyte. So grossly, this is the entire tumor here. They are paler than your surrounding myocardium. I think this is one of the residual myocardium here. So they are actually paler compared to this area. They have a fibrous texture on cut section. They resemble infarction. I think this is what the authors is telling us here. And this is actually areas of fibrosis on microscopic examination. They are described to be circumscribed, but have a poorly defined border. So they are mainly present in the left ventricle. About 90% is present in left ventricle. Microscopically, they are very similar to your hypertrophic cardiomyopathy. So we have myocyte hypertrophy, enlargement and squaring of the individual nuclei. There are myocyte disorganization or disarray. We can see here, even at this magnification, some of the enlarged nuclei, very pleomorphic, and with an admixed adipose tissue and blood vessels here. You can see here the thick-walled arteries and dilated venules here. So here we have, they did here some trichrome stain showing the interstitial fibrosis. This is also your elastic stain showing some of the blood vessels here. The blood vessels, this is CD31 showing the mesothelial lining of the blood vessels. This is a desmin showing the positivity of your hypertrophic disorganized cardiac myocyte. And this is your smooth muscle actin showing the smooth muscle layers in your dilated venules, your blood vessels. Again, another section with your hypertrophic cardiac myocyte arranged in this array, interspersed with dilated venules, blood dilated thick-walled arteries, and I think there are some adipose tissue here. Okay. So again, the main differential diagnosis here is your rhabdomyoma, but of course, your rhabdomyoma is almost always associated with tuberous sclerosis, while hamartoma of mature cardiac myocyte is not. Your hypertrophic cardiomyopathy, now to differentiate this from hypertrophic cardiomyopathy, this one does not really form a specific or discrete lesion compared to hamartoma of mature cardiac myocyte. But this is again not easy to differentiate, and of course this one is associated with your germline mutation. So you probably need to do more workup to differentiate this from hypertrophic cardiomyopathy. And also another differential diagnosis is your histiocytoid cardiomyopathy, which I will discuss a bit later. Well, this become a differential diagnosis because this is also a differential diagnosis of your hypertrophic cardiomyopathy. So in short, this can be also confusing for both lesions as well. Now, this hamartoma of cardiac myocyte is again one of the pseudoneoplasm that can recur. It can recur, but very low degree of recurrence. And again, because of the suspicion for malignancy, this is very important to differentiate with one another. So in our center, we have the similar case about 3 years ago. So the presentation of this patient is episode of cyanosis with difficulty of breathing or chest pain. And effectively, we signed this out as hamartoma of mature cardiac myocyte. This was actually the first in our center for this case, but probably in other center they have this lesion as well. Now, this was not discussed in that article in the archives of pathology 10 years ago, but in the 2015 classification of tumors of the heart, the papillary fibroelastoma was included in the section of tumor-like lesions. So sorry, sorry for that. So there are debates whether this is really a true neoplasm. Of course, in our standard textbook, this was also included as a true neoplasm, a benign neoplasm of the intracardiac or located in the heart. But the debate is whether this is a neoplasm, a hamartomatous growth, or a reactive process. So your papillary fibroelastoma is described as your benign endocardial papillary growth that histologically resemble your lumbal excrescence, usually located in your aortic valve. They resemble actually your sea anemone, and the theory for the development of papillary fibroelastoma is this is due to successive organization of your fibrin deposit. And the papillary fronds is due to exposure or repeated exposure of the lesions to hemodynamic stress of a flowing blood. Okay, so that's this. So the main significance of this is that it can emboli, especially with the papillary fronds here. It can develop, the patient can present with syncope or transient ischemic attack. And if some of this lesion prolapse to your coronaries, it can cause chest pain. So they are grossly described as soft, rounded nodule that expand when placed in your fluid, like this one here. So basically, they are very similar to your sea anemone. They can be present in your aortic valve, mitral valve, or even in your left ventricular endocardium, and very rare in your tricuspid valve. So this would appear like here, amorphous, like a fibrin material surrounded by your layers of mesothelial cells. Now, in the main differential diagnosis here is your lumbal excrescence. There are authors who said that we cannot actually differentiate papillary fibroelastoma from lumbal excrescence, although they mentioned that papillary fibroelastoma has several layers of mesothelial cells, while your lumbal excrescence usually have a single layer. But they said it's difficult to differentiate from that criteria alone. By location, your papillary fibroelastoma should be located in many parts of the heart, while your lumbal excrescence should be located basically at the site of closure of the valve, because this is just a product of endothelial damage in that area, in the endocardium. But maybe later we can have more discussion on how really to differentiate the two, the lumbal excrescence versus papillary fibroelastoma. So my discussion for fibroelastoma is just short, as this is only included here because of that particular classification. Next lesion is your cystic tumor of your atrioventricular node. The older term for this is your mesothelioma of the AV node. And unfortunately, the most common presentation here is sudden death. So most likely, this is an autopsy case. Basically, the pathogenesis for this is that they originate during embryogenesis of the heart and is derived from congenital rest of your endodermal origin or ultimobranchial heterotropic elements, similar to the solid rest of your thyroid. So this is more of a result of dilatation of your cystic space rather than cellular replications, indicating that this is not really a neoplasm, and basically there's an absence of mitosis. So grossly, they can range from 2 millimeter to 2 centimeter in diameter, multicystic when cut section, and of course they are located at the AV node. So this is the cross section here. They're made of multicystic structures. The lining can range from squamoid to transitional epithelium, and they can be filled with calcification or luminal debris. Here, these are the cystic lining cells, And they are positive for cytokeratin, AE13, and epithelial membrane antigen. Sorry. Here, a closer magnification here. The lining can be squamoid or sometimes flattened, flat cuboidal cells, but similarly, they contains keratin and some calcification, and sometimes some clear cells, occasional clear cells resembling the sebaceous gland. But we do not see here basically smooth, clear-cut smooth muscles, no evidence of mitosis, no atypia. So positive for CK, the lining cells, again, CAM5.2, AE13, 34B12, CK56, EMA, and there's a minimal K67 expression. So the differential diagnosis here is actually varied from myxoma. That it is the differential diagnosis here as myxoma is basically based on the presentation and imaging perhaps rather than the histomorphologic features. But other differential diagnoses include your bronchogenic cyst, your mesothelial cyst, your teratoma, uh, of course, because of the presence of those keratin and squamous lining epithelium, an ectopic thyroid, probably because some of the cells would resemble some of the thyroid follicular cells. Again, the histiocytoid cardiomyopathy and metastatic carcinoma, if those cells, like they would, if there would be a predominance of your clear cells in those cystic spaces. So the last lesion we have here is our histiocytoid cardiomyopathy. This is actually extremely rare lesions in the heart. And again, the presentation is sudden death or fatal arrhythmia. The old term for this is an oncocytic cardiomyopathy or Purkinje's cell hamartoma. So this is an autopsy case. Here we can see grossly the appearance would be a rounded endocardial nodule, usually located in your ventricles. So this is the appearance. So yellowish rounded small nodules, and then later, in a higher magnification, showing some a bit translucent nodular with light yellow surface. So microscopically, they are defined. The cells is made up of clusters of your large polygonal histiocytoid myocytes. This is the lesion here. This is your normal myocytes, and this is the cardiomyopathy cells, histiocytoid cardiomyopathy cells. The nuclei are round, oval, with evident nucleoli, and you can actually observe this in all layers of the cell. So they can be infiltrated sometimes. Here again, so the cells here are believed to be transformed myocytes. They are like metaplastic or transformed myocyte to Purkinje cells with accumulation of mitochondria. So this is the reason why they are called oncocytoid cardiomyopathy. They probably present a bit of an oncocyte and granular cytoplasm in some areas here because of the accumulation of those cellular organelles here. So this is again a portion of your histiocytoid cardiomyopathy, and here I think they are interspersed in between those cells, cardiac myocytes. So this cells is positive for MyoD1, muscle-specific actin and myoglobin. This one is desmin positive. So these are the desmin positive cells. This is an anti-mitochondrial antibody signifying or confirming the presence of your mitochondria. This is your MyoD1. This is your muscle-specific actin here. And again, another for muscle-specific actin here. sorry, this is our myoglobulin. So your main differential diagnosis here for histiocytoid cardiomyopathy is your hypertrophic cardiomyopathy, usually from Pompei's disease, which is a glycogen storage disease. So like in this case report, the initial diagnosis here is cardiomyopathy in Pompei's disease. And the initial impression here is a histiocytoid cardiomyopathy, which is a mitochondrial disease. But eventually with further studies, I think with molecular profiling, they were able to differentiate the cardiomyopathy in Pompei's disease versus histiocytoid cardiomyopathy. But of course, they do not offer any specific histologic appearance that would differentiate the two. Basically, that's the lecture. So in summary, I discuss the cardiac pseudoneoplasm, the inflammatory myofibroblastic tumor, the mesothelial monocytic cardiac excrescence. We discuss also the lipomatous hypertrophy, the hamartoma of mature cardiac myocyte, the calcified amorphous tumor, papillary fibroelastoma, the cystic tumor of the atrioventricular node, and histiocytoid cardiomyopathy with, with focus on their differential diagnosis, gross appearance, histologic features, and some ancillary studies to differentiate this from other lesions. In addition, also, your histiocytoid cardiomyopathy would always present also with your arrhythmia, sudden death, or cardiac disturbances, or electrical disturbances. And so most of the cases are from autopsy also. Thank you. That's all for my lecture.
Thank you so much, Philip, for your selection of topic and also for taking us through such a wide variety of lesions in such a competent and lucid manner. I think, individually, each one of us may have just seen a few of these cases. My own experience consists of the collected slides that I have seen at KEM Hospital with Pradeep sir and at AIMS with Dr. Uma Ray. So I'm actually very excited to hear from our seniors about their experiences over the years and all the lesions that they have come through. I also noticed that one of the articles that you have cited in your talk is a case report published by Dr. Sudhir Arava, and he's in the panel today. So I look forward to everyone's remarks, and I'd like to open the topic up for discussion.
Yes. So basically, for my experience is limited, but I hope our other esteemed cardiovascular pathologists can share some of their experience of this pseudoneoplasm.
Yes, exactly. These lesions are so rare, but that doesn't take away from their importance, because I think it's so important to know what is normal and what is abnormal, and also what is benign and what is malignant and what can mimic a malignancy. So, just because a lesion is rare doesn't take away from its importance. I'm sorry, someone is talking, but you need to turn up your volume.
Oh, sorry, Saranya, that was my another
Hi,
webinar.
sir.
This AIMS webinar was going on. Dr. Philip, it's an excellent lecture. You covered all the non-neoplas tumorous lesion, tumor-like lesions of the heart. Very nice presentation.
Thank
So
you.
I have seen few cases, and because autopsy here is very less in our center, All India Institute of Medical Sciences. Histiocytoid cardiomyopathy we have seen, and fibroelastoma we have seen. Then hamartoma of mature cardiomyocyte is the only one case we have reported. And calcific amorphous tumor, I have not seen that. I've just read about calcific amorphous tumor. Then fibroelastoma, yes, it is quite common here. And we have seen a good number of malignant cases also here. And mice, I don't know, even we had 2 cases of mice. So always literature says the patient had some kind of a cardiac intervention for the development of mice. So out of 2, 1 patient, he never had any kind of a cardiac intervention, but we found mice-like structures when they took out a small nodule. So how can we explain this? Do you have any idea regarding this?
My experience with mice, I only also a couple of cases,
I know it's
two cases also, but both have a surgical intervention done for this patient. So I haven't encountered mice with no surgery done on that intrathoracic space. So based on the pathogenesis, the suggestion is that it's due to mechanical intervention in that part, but
yes.
I have no other readings about spontaneous appearance in the patient. So maybe um, other members have other experience with
Yeah.
this.
At your center, uh, how common do you see this tumor-like lesions in live patients?
Because our center is basically a surgical cardiovascular surgical center, so most of the patient will definitely undergo surgery unless there are contraindications. So um, most likely um, I only encounter personally mice twice, but I think over 20 years, I think there are several cases as well, but they were not probably, I've not seen them personally probably. So most of them really are with surgical intervention. So
That's
I don't, I cannot, um, but there are also mentioned that you can see this in those undergoing endomyocardial and transbronchial biopsy. So the transbronchial biopsy is, I mean, this is still an intervention, even if not directly into the space. So
that's
probably some mechanical forces would still cause this. So I think my theory is that even if the patient did not undergo a specific surgery, maybe some mechanical process was done, like a biopsy or not exactly in that space. Because yeah, they mentioned a transbronchial biopsy can cause
yes.
um,
Have you
mice.
seen any cases of ectopic tissue in the heart?
The hamartoma, the
Ectopic tissue, ectopic
uh,
organs in the heart.
no, not from my experience
Okay.
having encountered ectopic tissue.
Philip, I'm so sorry to interrupt the discussion, but could you stop the screen sharing, please?
Hey, sorry.
Yeah, thank you.
Yeah, Dr. Philip, excellent lecture. Thank you so much. Yeah, like you said that these are like really rare cases. Like so, we do see like very few cases. We have seen three cases of mice, and like Dr. Sudhir said, like two had procedures and one didn't have. So it was again like there was no possible reason. And like now you're saying that maybe a transbronchial biopsy, or we don't know. Like so, there are hypotheses which have been put forth, and but the exact cause for this mice is not really well documented. So
Yes,
but it's very important that as pathologists we know it, because otherwise they look so epithelial, and you can
yes.
mistake it for metastatic carcinoma. So that is very important.
Yeah,
And very nice lecture, thank you so much.
thank you. So for the mice, our concern basically in the center is this can be a metastatic adenocarcinoma. Um, um, yeah, so I don't have any additional information whether about the spontaneous occurrence of mice, but I would think that probably some other intervention, not necessarily surgery, was done to the patient that that can so that this would happen because it can be initiated by suction catheter tips or um, other surgical instrument, so not necessarily a surgery. I'm not sure, but if it's really spontaneous without any total intervention, so it's probably a good point to explore that the pathogenesis, exactly how this developed without surgical intervention.
I would just like to comment. I think it was a very wonderful lecture, and we got to know of a lot of so-called exotic lesions, which are very rare and far and few in between.
Yes.
I have a few issues of why would you like to put a cystic tumor of the AV node under pseudotumors? And secondly, when you're talking of histiocytoid cardiomyopathy, wouldn't it be a more diffuse lesion rather than focal uh, neoplastic mass lesion? I mean, all cardiomyopathies are more or less diffuse lesions, no, involving the myocardium. So,
Yes.
why would you call a histiocytoid cardiomyopathy a pseudotumor or pseudoneoplasm?
Sorry. So for this, for the first question, the cystic, the sorry, I haven't done that. I haven't uh, understand the first question, the cystic tumor of the
Yes,
AV node.
it was earlier called mesothelioma of the AV node, etc. But why would you categorize it under pseudotumors or pseudoneoplasms?
Yeah, so in the original article they describe only five the first five lesions, but in the WHO, the 2015 classification, they include the papillary fibroelastoma and the AV, the cystic tumor, the AV node as tumor-like lesions already. So this prompted me to include them, to discuss them here. But I don't really exactly. They did not elucidate why they classify that, but they did not classify that under benign neoplastic tumor. So there were no explanation in that article, but I think there are some studies that probably they theorize that this could be there are questions about the neoplastic natures of these lesions. So that's why I included this in the discussion. For the histiocytoid cardiomyopathy, although they do not really form specific mass, but there are few cases like in this article that I cited that they form really some clear nodules within the ventricles, and that prompted them to add this as part of your histiocytoid cardiomyopathy as a pseudoneoplasm. I mean, quote unquote pseudoneoplasm, because they can sometimes grow very big. And yeah, also there are other several lesions pseudoneoplasm, but we just limit this to um, I just limit this to things that could really grow very big. So that's the main reason. There are few case reports that they produce not discrete, almost discrete lesions in the ventricle. So the histiocytoid cardiomyopathy was included, but I agree that this is a cardiomyopathy, so they do not, in general term, they do not really form discrete specific lesions. But I think because of the some case report, they shows some of these cases shows discrete lesion, big focal discrete lesions. So that's the reason.
I think Dr. Pradeep has published a case of inflammatory myofibroblastic tumor, if I'm not mistaken.
No, not yet.
No?
Thank you, Dr. Philip. I just want to add a few things. Number one is about this cystic tumor of the AV node. See why I don't know why it was called as mesothelial, because it is showing all types of epithelium, And in the photograph which you showed, there was something looking like almost like a sebaceous differentiation.
Yes. Yeah.
So it is almost as if it is some kind of a leftover in the development, whereby it sits between, say, something like a undifferentiated foregut cyst and between a teratoma, because it is mostly showing like a squamous differentiation. I mean,
Yes.
this is just my hypothesis, because, and I mean, most of the people have not shown, sort of mesothelial markers in such lesions. Then about number two, I was thinking about this papillary fibroelastoma. Uh, have you seen any demonstration of the elastic fibers within the core of these papillary fibroelastoma papillae? Because some of the people say that it almost looks like the chordate tendinae, because it is definitely having a core of elastic fibers, and that is how you're able to differentiate it from the Lambel's
Mhm.
excrescences. Any
Okay.
comment on that?
So in our case, in our center, we do not do any further studies with papillary fibroelastoma. So we just signed it out as we rarely encounter the lambal excrescence actually. So
Okay,
for papillary, we were not in a circumstances where we have to differentiate between the two. And
okay.
although
Mm,
we have elastic stain, we do not do further studies, and that is a good information because the article in that particular article they said that they cannot differentiate it
mm,
microscopically. Although they mentioned
yeah.
the mesothelial lining is more, there are multi-layered mesothelial cells in fibroelastoma and papillary
Endothelial.
fibro, yes, compared to your lambal excrescence,
Mm.
and also based on location, because papillary fibroelastoma can be seen in many areas of the heart,
Yes,
while
yes.
the lambal excresses in the site of closure.
Mm,
And they also said that the fronts in papillary fibrillosome is more elaborated compared to lambal excrescence.
right,
But
right.
I don't have experience with the use of
Mm,
elastic stain to to
yeah,
differentiate it, and that should be a practical way,
right.
right?
And I agree with Dr. Deshpande when Madam said that histiocytoid cardiomyopathy is actually a wrong term to be used, because you don't have involvement of all the myocardium. It is only that you have a transformation of some of the cardiomyocytes into that histiocytoid or Purkinje cell morphology. And that is why you have these cells focally forming those paler nodules, or like polypoidal, very quite soft nodules. And of course, unfortunately, I don't have any experience at all with this hamartoma, or with histiocytoid cardiomyopathy, and even with this cystic tumor of the AV node. But we have seen three cases of the cat.
Oh,
And what I feel, it is just a fancy term which is used to describe a thrombus which has been present for a very long time.
Exactly.
I had seen two cases. One was, of course, a referral case from outside. And in one of the cases, we had actually seen a calcified tumor even in the inferior vena cava. And also, there was a total block of the right pulmonary artery. So, that person had calcified lesions in the IVC, right atrium, as well as in the right pulmonary artery. And in fact, the right pulmonary artery was totally occluded. So it was really surprising that how the patient waited for, so long before finally he came to our center. Can I share that slide, Sharanya? Is it possible?
So actually, before that, I just wanted to jump in on CT-AVN because earlier in the year, I had reviewed CT-AVN for the Blue Book with Dr. Stephen Cole. And actually, it's like, when I was reading for it, it's actually thought to be a very early embryological defect. So, it occurs at the stage where, the midline of the body is defined and the dorsal and ventral surfaces are defined, and the early cardiac folding takes place. So it's actually, thought to be a defect in the migration of those early embryonic tissues. So
Yeah.
you had said something about it, being somewhere close to, a Fogart cyst or a teratoma. So it's actually a migration defect, which if you think
Hmm.
about it, even a teratoma is exactly that. It's just like,
Yes.
a migration defect, basically. Yes, sir. So you can go ahead, you can share your screen, sir.
Yeah, this is the first case of that calcified amorphous tumor. And I don't think I should describe because Dr. Philip has described it very beautifully, especially that chalky appearance, very well seen in this. So this was almost like a 8 centimeter mass which was present, and it showed that usual calcification and fibrin and all that stuff. And this was the second case where there was a mass in the right atrium as well as a mass in the right pulmonary artery, which was practically totally occluded. And unfortunately, this patient expired, and we can see some remnant in the right atrium. This is the pulmonary artery, the lumen of which is totally occluded, as you can see here. And this was the IVC, the inferior vena cava, which was also showing that calcified tumor. And one more pseudoneoplasm, which we have to think, especially in this part of the continent, is tuberculosis. So this was a very large tuberculoma which had projected into the right atrium, forming a mass lesion. And when I presented this particular case, the first diagnosis which I got was a cardiac sarcoma. So this, you can see that there is marked thickening of the right atrium, and all this material was caseation necrosis, and it had projected as 1, 2, and 3 polypoidal masses within the right atrium. So somewhere I think for any mass lesion, we always have to consider tuberculosis.
Yes, sir.
Yeah,
In fact, sir, even the last two cases, of pseudoneoplasms that I have seen, both were fungal endocarditis actually.
yeah,
One was candidal and one was aspergillus. So, it's like you should always
yes,
have fungus of
correct,
fungal
correct,
endocarditis in
yes, yes,
Even infectious disease they should include. Even we had one case of a hydatid cyst presenting, and clinically they were thinking of teratoma in the
yes,
interventricular septum.
yeah,
So infectious disease, bacteria, fungus, they
correct.
should be included in the classification like tumor-like lesions,
Yeah.
infectious.
I think
But
Dr.
we don't
Gayatri
have.
also had one case, isn't it? I think Dr. Gayatri has unmuted. She has
Yeah,
to
Yes,
yeah.
un.
we have.
Yeah,
Oh.
yeah. We had a similar case. It was a young girl, like where there was like it was involving all the three layers, and like the endocardium had these nodules, like it was almost forming like a mass-like lesion.
Hmm.
So yes, TB can present in any form, like so.
Yeah.
Hmm. Sir, I think you also had a case of intracardiac bronchogenic cyst in your
Yeah,
collection.
but somehow I just could not find that PowerPoint today. Maybe next time, if in case we have a slide seminar on
Yeah,
pseudoneoplasms,
that would be
then
nice.
maybe we can show it that time. It'll be
Yes,
nice.
yes,
And
sir.
the other thing which struck me is that Pompey's disease may not always come in the differential diagnosis, because Pompey's disease is going to involve the entire heart.
Uh,
It not will be like a localized lesion. Okay, microscopically, yes, but when you look at the clinical scenario, it is unlikely to form a differential diagnosis.
So also on, just a thought on inflammatory myofibroblastic tumor. I'm wondering wondering if it's actually two different things which are somehow, being categorized together, and maybe somewhere along, down the line, people would split it into two groups, because, some of the lesions show ALK mutations and they're more likely to be towards the neoplastic spectrum,
Right.
but others
Yes.
do not show the mutation. So maybe, there are actually two different things which we are kind of clubbing together right now in the
Yeah.
present
No,
classification.
it can even be IgG4 disease.
Nowadays,
Exactly.
it's
Dr.
more
Philip, have you
common.
done IgG4 in your cases?
No, we haven't
No.
done actually.
Okay,
It
because it
is
is
ac-
really
Look into it.
worthwhile doing.
I
it is
definitely
actually
think,
also
we should
material.
all put our heads together and maybe, publish another review article, since
Yeah,
it
definitely.
doesn't
Yeah,
seem
I
to be
agree.
keeping
Yes,
decent
yes.
in the literature.
We had one case way back in 2010 on I call it as inflammatory pseudotumor. But that time, of course, this IgG4 was
It was
not very much there. So maybe now I can do the IgG4. Yeah.
Yeah, particularly if it shows lots of plasma cells, it would be worth to do.
Yes, yes, yes.
But somehow, ma'am, it's like, so many things in the heart, like even myxomas now, they tend to show so many plasma cells, like sheets of plasma cells. So there's some, I don't know, some
IgG4
cytokine
is
secretion or something
becoming
happening.
so non-specific. Every other lesion has plasma cells and will show IgG4.
Yeah.
Are we going to call it IgG4 disease?
No, it
That
has to be
much.
that.
now
There has to be
ratio,
that ratio.
ratio.
Yeah.
Yeah.
Yeah, that is very
And I
important.
think also, the vascular changes, to actually call something IgG4 disease, the storiform fibrosis, and actually the vascular changes are also really important.
Yeah.
Are there any more comments?
Yeah.
Maybe your tuberculoma case is very nice. I still can't forget the tuberculoma which madam had, Indra madam. Yeah, you must be remembering.
Yeah.
Huge tumor in the right atrium.
Mm.
That was just so wonderful. And you also, I believe, you had hydatid cyst on the tricuspid valve, Pradeep,
Oh, yeah, yeah, we
uh-huh,
had.
which
Yeah.
had embolized to pulmonary artery and
Yes,
all.
yes, yes, yes.
And your
That person had, I
Massive.
think, almost like 200 hydrated cysts sitting over the
exactly.
heart. It was like literally like that.
Indeed.
And for the first time, we had seen like a vegetation. It was sitting over the tricuspid valvular leaflet. I mean, maybe I can show next time. Yeah, yeah. Oh, thanks, madam, for reminding. I had forgotten about that
About
case.
your calcified tumor,
Huh.
did that patient have an emboli in the heart, I mean the lungs?
No,
Because pulmonary artery was blocked.
yeah, no, but did not have at autopsy, no. At least whatever sections we took, that did not demonstrate.
It was
No.
not a thrombotic disease, no?
We don't know because
Thromboemboli.
unfortunately, that's why I would advocate that in all these cases of so-called CAT, they should definitely rule out a hypercoagulable state, especially the rarer types like say
Exactly.
protein S or protein C. In our case, in the first case, the patient was protein S, protein C negative, and in the second case, it was not done, unfortunately.
It's not possible in the autopsy cases to get these things done, no? Many
No, not
times.
like that. Even in prospectively, they had not done. Whereas in the first case, they had done. Since the patient was still, I mean, was alive after uneventful
Oh,
surgery,
okay.
they prospectively they did protein S and protein C, which came negative that way.
And that histiocytide cardiomyopathy, Dr. Philip, what was the age group did you find these patients of histiocytide cardiomyopathy? Only in infants?
Sorry, IMT. Is it the IMT?
No, no, no. The histiocytoid cardiomyopathy,
Cardiomyopathy cases.
does it
What was
occur
the
in the young?
age group?
Yes, these are from the literature that I have. There are in the young usually, like under 5 years of age.
Oh, 5 years of age.
Hmm.
Because they are generally described in infants, isn't it?
Yes, also
Yeah.
the case with Pompeii's disease that they initially use as initially think that this is due to Pompeii's disease is an infant, but most of course because of the presentation or mostly are autopsies. I only encountered maybe 4 literature about this histiocytoid cardiomyopathy, mostly below 5 years of age. Yeah. 5 years or
Dr.
younger. But
Dr. Sudhir, you were telling about ectopic tissue. Have you encountered any?
Yes, yes, we had one patient. I don't remember his age exactly. Somewhere around, I think it's second decade. He presented with interventricular tumor, mass-like lesion. So it was well circumscribed. When they excised, it was ectopic thyroid.
Oh,
Wow.
my
oh,
goodness.
Ectopic thyroid.
I think this you published.
Yes, yes, yes.
Yeah, I remember. Oh, right, right.
So very nice. First time.
Where of the ovary. It's
I think possibly it must be, like, related just to, migration of early tissue.
Yes, exactly. Yeah.
They just kind of get entrapped, I suppose, while the folding is taking place.
Right, right. Yeah.
So then theoretically, you could have like all kinds of tumors arising in the thyroid, and you could have all kinds
Yeah.
of
Like they
Yes,
have
yes, yes,
described
yes.
even thymomas arising in the myxoma.
Mm.
So everything is quite possible.
Similarly for mice also they say that, like, especially in these patients who've not had any procedure,
Right.
again it could be like a primitive cell, and which is differentiating
Mm.
into like epithelial mesothelial markers. And so, like, I think a lot of things have to be because of this migration process, a
Right,
lot of
right.
these pseudoneoplasms
yeah,
can be
because
explained, like.
yeah, increasingly there are more and more articles about the contribution of the neural crest in cardiac septation. So that's like a critical area where things would get entrapped, right? So anything which develops from the neural crest can theoretically occur then within the heart. So I mean, it's like it just finding them is, I think, based on the autopsy rate and how many autopsies you actually do and how carefully you actually examine.
That is true.
Any Facebook questions?
I don't. Pranita, is there anything right now? Just some remarks. Very good presentation. Thanks for the lecture. Glycomatous
Yes.
septa will get more attention in our center now on. That's a friend. That's a colleague from Hungary. And thank you for sharing your knowledge in an excellent conference, Dr. Templo.
Yeah, excellent.
thank
Yes,
you.
it's a wonderful thing. Thank you
Yeah.
so much. Are there any more comments or remarks?
Sir, have you ever encountered any kind of a stone in the pericardium? We had one case that we published. So,
Stone in the pericardium.
yeah, I searched the literature, nothing. Ultimately, I only named it as pericardiolith. So,
Nice.
so
How large was it?
it was about 1 centimeter, very smooth surface. Then these kind of stones I found while reviewing literature in thoracic cavity when they have chronic pleuritis kind of lesion, where they call thoracolith. So
Okay.
It is
and
common
and
No, I'm just
pericarditis.
wondering whether it can be even what shall I say, calcified lipoma.
yes, same thing. Then
Calcified
I
tuberculoma.
no ma'am. A
Yeah.
patient had he was somewhere around 75, 7th decade and nearly 8th decade patient. He had a chronic history of rheumatic heart disease. So we had pericarditis.
Hmm.
Then when I took sections and I saw actually it is a necrotic fat, so which got dislodged, calcified,
Hmm.
and it became a stone.
This is
Stone.
like
Okay.
similar to peritoneal mice, then which
Peritoneum,
sometimes
exactly.
get
Exactly, yeah.
the
Peritoneal
Yes.
mice.
Peritoneum.
or
And
something
it
like
is a
that.
freely, it was almost like gallbladder, any gallstones, kidney stones,
Hmm.
very round and shiny, white in color.
Yeah.
In the center of the thing, I could make out some fat cells with necrotic.
Correct. Yeah.
More
So
common in
No,
Sudhir,
pericarditis.
in
Sudhir, you
fact,
can
in
keep all exotic cases like thyroid and stone
But
and
now I want to see photographs.
yeah. In fact, in 1988, we had a liposarcoma of the peritoneum, and that had multiple lobulations on the external surface. And some of those lobules got twisted and they formed about 9 stones in that patient.
yeah,
It looked
please.
exactly like the pebbles which you get, no?
Okay, yes,
Could
sir.
be kept used as a paperweight. It was that nicely polished. It
Yes,
looked like a
that's
Oh,
shiny
similar.
surface. Very
Yes,
unusual.
that's true.
Yeah.
You learn something new every day.
Yeah, I know exactly.
You learn many new things in one.
Yes, yes. I think maybe we should have had a companion slide seminar with his lecture.
Also, but we'll definitely put it in.
Yeah, yes,
Next time we
yes.
have a slide seminar, we'll try
Yeah,
to do some
definitely.
of
Very
these
nice.
cases.
Maybe we can have neoplasms and pseudoneoplasms together, something
Oh,
like
yes,
that.
and we'll
Yeah.
invite cases from around the world.
Yes, yes, definitely.
Can I
Very
share my
nice.
screen for a second? I'll
Yes,
show that,
sir, surely.
that pericardial lid. So all of
Oh,
it.
very
Oh,
good.
yes, we want to see it.
I'll just
Yes.
share. One second. So actually, can you see this stone? Bilobed, full
Oh,
polished stone,
wow.
Oh,
somewhere
it's
around one
nice.
centimeter. And this is actually in the center. There's fat necrosis and lamellated calcification.
Right, right.
And
Oh,
here there's a floating stone, freely floating stone in the
oh,
pericardial.
nice. The
Oh, very
radiology is really
beautiful.
nice of you.
So I only named it as pericardiolith.
Very beautiful.
Right.
Nice.
Yeah.
That's,
He never had pancreatitis ever.
no, no. He
No.
had history of chronic
Any,
rheumatic heart disease.
Okay, okay.
so,
So
but
what
any
you
intervention or any, trauma or any history like that?
he had multiple interventions, and
Okay.
pericardial inflammation, as Pradeep sir mentioned, the pathophysiology is same. The pericardial fat, it will get dislodged from the surface,
Exactly.
and it will be freely floating. Gradually, fat necrosis, calcific deposit, and it forms
Yeah.
just
Yeah. So actually, even in the peritoneal cavity, they occur
same
after
processes.
intervention.
Yes,
Yeah,
yes, you're right.
yes, yes.
Same.
Yeah. I think that's really interesting, actually. So it
Very
was
beautiful.
freely moving, free floating stone.
Yeah, amazing.
Mm.
Nice. All right then.
Mm.
Any more questions or remarks?
Very nice.
Good.
Thank you, Dr. Philip. Excellent presentation. Wonderful.
Yeah.
So
Thank
Lisa,
you.
maybe you could stop the screen sharing.
Oh, one second. I'll just do that.
So our next meeting will be on the 10th of
1 second.
October. So I think we continue on the 10th of October with part 2 of Sir's 4-part series on cardiac anatomy and dissection.
Oh, wait 1 second.
You're showing us a thyroid also?
Sir, it is not there in this desktop.
Oh, okay, okay.
Sorry, there is some. I don't know how to this enlarge. Okay, so I'll just.
I overrode it.
Yes. Yeah. Thank you. Thank you.
So all right, so then we meet on the 10th of October for part 2 of Pradeep Sir's 4-part series on cardiac anatomy and dissection, and part 2 will focus on the coronary arteries and the myocardium. So we look forward to everyone's participation there as well, and we hope that Philip will continue to join us for all our meetings.
Yeah.
Yeah, it
For
was
sure. Yeah.
Join
too
us.
good. Once again, excellent job done.
Thank
Thank
you.
you.
Thank you so much.
you.
Thank you so much. Thank you.
Thank you.
Thank you.
Thank you.
Nice.
Thank
Thank
you.
you.
Thank you, Philip.
Bye.
Thank you, everyone.
Thank you.
Yeah, bye.
Thank you.
Bye.
Thank you.